using registries can help to improve quality of outcomes. The first slide, the next one please, shows you that just having a registry is not enough. You see, I think, well-to-do countries amongst Europe and also across the Atlantic who have registries, but nevertheless, although the age-dependent rise of A1C is very, very similar, the level of A1C is quite different in these countries, and all of them have registries. So registries alone doesn't do it. So what was our idea? And the next slide shows you what the excellent work from the European Union actually has started way back then in 2008, when they said, well, we need to do something. We visited the European Parliament, showed them how technology, diabetes technology, may change the way that children with diabetes are treated. And they said, yes, we will support a program to develop centers of reference for pediatric diabetes. And now, nearly 12, 13 years after this initial time, I can show you what has happened. It was our vision to have equal high-quality care for children with diabetes. And in achieving that, the mission was to harmonize care, to optimize outcomes in children and adolescents with diabetes, first within Europe and meanwhile worldwide. The next slide shows you how this all has started. So it was part of the EU public health program in 2006, and we agreed not only to have a registry that was based on the standards of care which were put forward by the International Society for Pediatric and Adolescent Diabetes, which is part of this EUDF forum, but not only to collect data, but also have a peer review, audit, and regular quality control circles to improve care. The next slide shows you how it has developed now. It's a worldwide registry, has more than 140 centers around the world, but the next slide shows you that actually in Europe, we still have the majority of the centers, and obviously we are trying to harmonize it in Europe, but also beyond. The next slide shows you how we were able to analyze from this very, very beginning, not only in Europe, but also abroad, 22 centers that have been there in 2008 and 2018. What has happened since? And this was published recently in Diabetes Technology and Therapeutics. The next slide shows you comparing it to the Type 1 Diabetes Exchange in the US. And you see that, yes, there is a difference still between registries, but the good news is that SWEET was able to improve in every age group the average A1C in these 10 years. And this was actually happening in 21 out of 22 of these centers. The next slide shows you, and please recognize that this is, of course, real-world data. It's not a controlled trial, so it's difficult to judge how much these things are actually just a coincidence or whether it's really the cause that led to change. But it is apparent. If you look at the yellow bars, those are the patients who are meeting the treatment goal of an A1C below 7%. And it appears that, for example, the use of diabetes technology, which is diabetes pumps, insulin pumps, which is the brown bars, which is actually rising before actually there's an improvement in A1C, in the percentage of A1C seen. And there's even another rise of CGM, again, preceding another improvement in target achievement. So, well, we don't exactly know whether technology does really lead to the change, but it is at least pointing in this direction. The next slide shows you how we are doing it to really improve our control and how to make these judgments. You see a benchmark, which is, of course, far too small for you to judge, but it shows the different parameters. It shows you whether or not the data completeness is achieved, because only if you really collect longitudinal data of good quality, then you're able to really make a good judgment. You see it's different in different parameters, so this is a very important part of it. It looks as if we have less patients, but please realize This is the first upload in 2021. The second upload, of course, will appear later this year, so the number of patients will increase. But overall, we can see that data completeness over time with such a dashboard is improving. The next slide shows you also that such a registry helps you to look at the rapidly changing way that we're looking at glycemic control. There's a lot of talk at the current ESD how diabetes technology will change the future of diabetes, that maybe even the A1C at some time might no longer only complement the continuous glucose monitoring data, but maybe even continuous glucose monitoring will become the standard. And you can see here when we are calculating the combined glucose indicator from the continuous glucose monitoring data of somewhat those centers who have data on this, you see that the median A1C is just the same whether it's measured or actually calculated in 26,000 children with diabetes worldwide. And even if we take the average A1C in all of those, whether they have CGM or not, we come to a very, very similar median A1C, showing you how diabetes technology may change our way of looking at it in the future. The next slide shows you how important it is really to not only to compare yourself with other centers to see what are they doing better, where am I doing pretty good, where can I learn something from somebody else, and where maybe I could serve as an example for another center, but also as we are getting better sometimes, but also getting worse sometimes, it's important also to look at the trend in your own center to see whether the ideas, the changes that you have undergone are actually successful or not. The next slide shows you that size doesn't necessarily matter. And you see the size of these dots is the amount of patients that are treated in an individual center. And so you can see, yes, we have big centers, we have low centers, at least 50 patients needed to be submitted to be part of this picture here. But if you click once more, obviously, if you have your center on the left side, you want to go down to the right side to have more patients in pretty good control. And so this gives you a chance to look at a center of a similar size, which may face similar problems as you are in your center. So the next slide shows you what is the uniqueness, I think, of the SWEET initiative. It's not only delivering the data, but also be part of a peer review. So in order to become a center of reference, you have to fulfill the criteria put forward by our scientific society, ISPAD, but then you are visited either in person, that was before COVID, and now we are implementing virtual peer review to alleviate all the problems that we have traveling right now, so that the center is looked at and we're actually learning from each center what is really working very, very well in the center, what can be done better. And this also helps the centers, of course, to collect data, to deliver care in the best possible way. The next slide shows you COVID. And because it was mentioned many times, of course, that COVID is a big thing, and registries may help us to get an idea what really happened. And we looked into, we divided our SWEET registry in quartiles of background mortality. So the highest mortality would be quartile number 4 on the right side: Belgium, Chile, England, France, Ireland, Italy, Netherlands, Spain, Sweden, and USA, which were hit particularly hard during the first lockdown, the first wave. And the next slide shows you what happened to the children with diabetes. And if you click once more, you see on the right side, the major impact was in DKA, also DKA and follow-up. So as a sign of the interruption of care, the rate of DKA was increased significantly only in this quartile with the highest COVID burden. But the good news was immediately prior the second wave, so after the first wave, it was back to the baseline levels. showing that, yes, it was just a short period, and hopefully, if we look at the future waves, this immediate negative impact with the rise in DKA will not happen. But the good news is also on the left side of this slide, you see the A1C on average remain the same. And the next slide now shows you there and if you click once more, one really very interesting thing that the insulin pumps didn't change. Obviously, it takes a lot to start people to onboard them on pumps. But it also takes a lot onboarding on CGM. But CGM really increased significantly after the first wave. There was a big difference. So people understood with COVID how important CGM is in all quartiles of COVID burden. There was a significant increase of CGM use in children to manage diabetes. So really technology, if we look at the next slide, really appears to help with better outcomes. You can see that here, looking at the whole group of SWEET participants, the best results in terms of A1C, in terms of DKA and hypoglycemia is if you use diabetes technology. But it's not technology alone. And the next slide shows you how important it is to have targets. You need ambitious targets. And those centers who had the most ambitious targets appear to be also those who are reaching the best average glycemic control. And of note, there was no association between the education time or the full time employment of personnel and A1C. So it really appears that targets and treatment philosophy in those centers is so important. And it may be a little bit of a comfort for those centers who feel, well, all I need is a lot of money, a lot of technology, and a lot of personnel. No, I think it is really the multidisciplinary team and the cohesion in the team, and that everybody speaks with one voice. And this is something of learning beyond the SWEET registry. The next slide shows you now something also which may be misleading if you just look at registry data without knowing what is happening behind. Because if we look here at the long run, at the risk factors for complications, you might have the impression that nephropathy is rising in SWEET despite the better control. Well, this is clearly ascertainment bias, because we are really trying to improve our data, particularly also with the long-term data. And this is why we are capturing nephropathy better and better. And this looks as if nephropathy would be actually in the rise, although if we look a little bit closer, I'm pretty sure it is in the decline. But this shows you that registry always needed to be interpreted in the whole field of the background care. So what are now my take-home messages? We need to include the patients. And this is really the next step. We have done great initiatives of trying to involve patients, and but we really need to get the patient voice into our registry much more. We are in the process of creating a patient advisory board and trying to collect the patient-related outcome measures, which is, of course, worldwide with GDPR, not an easy task, but we are very optimistic that we find a good way of doing so. And so to finalize all that, if we look what should be used from the learnings from the SWEET registry by the decisions makers, I think we have good evidence that registries are effective, but we need to ensure the sustainability. Too many registries have appeared and then disappeared as financing dwindled out. We hope that the future advocacy will point in the direction that it's important to sustain the existing initiatives and join them instead of creating new registries which have a short life. And finally, the big hope is, of course, that the use of this data will be to translate it into healthcare interventions with the involvement of people of diabetes to really make a huge impact beyond the actual registry. And so I thank you very, very much for your attention, showing you that we are growing, whether it is in person or the next and final slide or virtual like this ESD meeting. Thank you very much.